myself. So I'm Sabine Prigione. I'm the chair for sex and gender sensitive medicine at the Radboud University in the Netherlands. And I used to work at the Institute of Gender and Medicine in Berlin. And before that at UC Davis in California. So basically I've been working on sex and gender differences in healthcare in the broadest sense for the last 15 years. And I came to share the frustration that a lot of my colleagues in medicine have with doing a lot of work and finding out a lot of things, but somehow nothing ends up in practice, or very little of what we do ends up in practice. So I'm mostly interested in how do we bring things into practice, and I somehow promised myself when I started doing my independent work that I would only do projects that have a relevance in practice, and otherwise I wouldn't be doing them, which is of course a big expectation towards myself, but I think I didn't want to write any more papers saying that we need another project to try that out in practice. So I'm going to tell you a little bit about how we consider gender aspects in two larger project areas that we're working on at the moment. Our focus is mostly on prevention and implementation. We do a very broad range of projects, and since we only have 10-15 minutes today, I'm going to cut that down, but I'm more than happy to answer any questions that might come up later on. So very briefly, first of all, why do we need innovation in prevention design? So that's the first question. Why do we actually need to do it differently? Is there anything that's not working, or what should we do differently? And then, as I said, I brought two small examples. One is why did we include gender in thinking about preventative offers for refugees? And the second one is, why do we focus on gender if we develop programs to prevent sexual harassment in academic institutions? So first of all, about gender-sensitive prevention, and is development of gender-sensitive prevention in any way different than general prevention? So when you look at this, so as you see, there's 4 different steps when it comes to how we develop prevention programs. So the first thing is we generate knowledge. We try to look up the literature, we try to find out what is relevant. And from that knowledge, what we usually do is if we're lucky enough, we jump directly to the solution proposal. So we come up with a solution on how to address the gap of knowledge or the need there is. And in some cases, we try to implement this. So in itself, the whole process is not gender sensitive. It only becomes gender sensitive if you actually put a focus on sex and gender at each and every one of these levels. So if when you do the knowledge generation, you start looking into sex and gender aspects, then this knowledge will have a sex and gender dimension. If you don't, it won't. The same thing comes down to the innovative methods, which I will be talking a bit more about, the solution proposal and the implementation. So it is not a given, it is really something you need to do objectively and right from the start if you want to incorporate that. We focus on 2 main aspects that we try to do slightly differently. So we do innovative methods, and I'm going to show you a few pictures about what that means. We think that our knowledge generation in medicine, we're quite good at generating knowledge, especially the traditional way. We're not so good at including our end users. We're not so good at talking to the people who will eventually pick that up. So we think that the way we've been doing prevention might not work that well in general if we don't open up a lot more to our users. And the other thing is, of course, as I said in the beginning, we're interested in implementation. So what do we need to do? How do we think about how to put what we're doing into practice right when we start a project? So it means that already at the level of project design, you need to think about who are you going to include as sparring partners, as stakeholders, as people involved with you, so that what you're producing will actually find its way into practice. And it's a different way of working. So very briefly, this is the result of 2 projects. We did one of the largest, it's actually the largest survey and interview with refugee women in Germany. We interviewed refugee women who arrived in Germany between 2015 and 16, more than 600 of them from 6 countries: Syria, Afghanistan, Iran, Iraq, Somalia, and Ethiopia. And what we found, and that was the scariest part that prompted the follow-up project, was that when women had medical complaints, be it physical or psychological, you're seeing the bars here, the most common reaction they had is this one, which is passive reaction. They didn't do anything. They felt sick for whatever reason. And 55%, in case of, unfortunately this is in German, physical complaints, didn't do anything. Or they did self-help, which is anything from I talk to my friends, I meditate, I go on a walk, I make tea for myself. only 15% said they actually looked up a physician in case of physical complaints, and even more scarily, only 4% said that their reference person would be a physician in case of psychological or psychic issues. What was relevant about this was we also looked at what determined their quality of life. And it turns out there's 3 main factors which impacted negatively on their quality of life. And one of them was actually lack of access to healthcare in case of need. So it turns out that we have 2 aspects. On the one side, these women don't go to the physician, they don't arrive there. And on the other hand, we're also seeing that not having access to healthcare impacts quality of life, which also impacts abilities for integration. So we said, well, we need to take a step further and think about how to practically tackle this. What are we doing wrong? Why is nothing happening? So we developed this project, which is still ongoing. It's going to go until the end of the next year and has 3 arms. I'm going to talk just briefly about 2 of them. The first thing is, well, we can go about this with classical methods. So we want to know what are the specific needs of female refugees. So we saw a lot in our empirical work, but what does the literature say? So we're going to do a systematic review. We're actually at the moment where we're evaluating which papers to include. But we also decided, okay, we're interested in the solutions. And the literature doesn't offer the solutions, especially not the innovative solutions. Because if you have NGOs doing innovative projects, you have initiatives outside of academia, you have all kinds of self-developed options that refugees do themselves, you will not find these solutions in PubMed or in Ovid or in Cochrane or whichever database we might be looking at. So we're combining this with searches on the internet, on platforms that refugees have developed themselves, networks, foundations to find these solutions. So we're going to do a classic review, and then we're going to couple that directly with the innovative solutions that we can find for these. Because our idea is, well, we don't just want to say what the problem is, we already want to see who is doing something about it and how can it be done. The other thing is we want to know from people themselves what they need. And it's very difficult to do that if I come with a qualitative questionnaire and I sit in front of somebody who's potentially analphabet, doesn't speak my language, has never seen a qualitative questionnaire, and has no idea of why I'm asking those questions. So it is quite difficult to have the information I need to know what is health for you, what is prevention for you, how do you go about it, what makes you feel better when you're sick, if I go at it with traditional methods. So what you're seeing here is an entire array. We work with a lot of designers and engineers and all kinds of different disciplines, and it goes from a transformed version of qualitative interviews where you really sit down with the person and you talk with them and you have the interpreter and you have people who are already involved. But we also did this. You don't need to speak any language to ask somebody, how do you perceive healthcare? So what you see in the middle, Google, they all know. So they're looking this up, and then the question was, what helps you to feel better when you're sick? And you have everything from the time and the people who help you and the religious support, and they can interpret these symbols as anything they want. I have no idea what this is, but they can tell me what they mean by that, and so they can bring in their own expertise. So it's also incredibly empowering because you can define what you're seeing in there. Then we developed some kind of prototypes where people can tell you, okay, I want to measure sadness for me, and I came up with this prototype. Basically, this doesn't inject anything. You put it on your skin, and it can tell you how and can measure sadness. So this is a prototypical idea of what somebody thinks is important and what they need. And of course, then it's up to us to see what do we do in practice with this. And then what we do is, with all these ideas, we fill these rooms, and then we have groups of experts, 4 to 5 people, who come in and tell us what we could do with these ideas, and it goes on and on. So we have experts, refugees themselves, and also people who deal with them. What we saw was that, and this is the relevance with the focus on gender, if we hadn't considered female and male refugees, and we didn't even go into other aspects of gender, we didn't even talk about inter and trans and anything else, if we hadn't considered these aspects, we would have never found out that, for example, the involvement of the peer group is extremely relevant for women. All the issues that are connected to minding children. What do I do when I need to go to the healthcare provider? I have these kids, and we need to somehow manage the situation, considering that the healthcare provider might be 2 hours away from where you're residing. With men, we have other issues. So, for example, the time commitment, they look for work, they look for, and at the same time, you might need to go to the doctor. So how do you combine these things? How can we bring these things together? Or how can we find ways to bring that together? When it comes to the implementation, and as I said, I only have a few minutes today to talk about this, we believe that it doesn't work if you don't start out with networks right away. So we need to have all our stakeholders at the table, possibly right from the start of the project. So we're 3 partners in this. So one is me with my Berlin team. The other one is the Institute for Social Innovations in Berlin and Fraunhofer. And this project is rooted in Berlin, but that also means that we need to have a lot of people in the community. So we have the politicians, we have the Senate of Berlin involved, the Equal Opportunities Officer, we have different foundations. These people actually run Tempelhof, which used to be our airport and now is one of the largest centers where refugees stay until they find their own home. TechFugees, maybe some of you know it, it's a platform for actually refugees to build their own projects. And then we have our academic partners. So without the network, nothing would happen. The second point I want to make, and this is a bit shorter than the other one, it's sexual harassment. I never thought that this was actually the research on sexual harassment would one day be good for my career and not deleterious. When I started working on this issue, I was like, this is a career killer, but I do it anyway because it's important. So we did this project, and this is one that really covers everything from finding out what the issue is, what do people need, and what can we do in terms of legal aspects. So the project had 3 arms right from the beginning. We had one arm where we asked people, what do you experience? So we wanted to know what's the prevalence in the institution. Then we had one where we did interviews with people affected or not affected and asking them, what do you think does work in your area? How would you design prevention measures in your specific field of research? And the other one was really, what are legal instruments and how can we develop these? Turns out that, at least in the institution I was working in, Charité in Berlin, 70% of all physicians that participated, and that was a response rate of more than 40%, experienced some form of misconduct. And that goes from verbal harassment, so from the minor forms, if you want, up to physical harassment, which was quite low percentages. But anyway, women and men. I'm not just talking, it's about the same. They experience different forms, but they both do. And this is submitted, so it will be published soon, we hope. So next to finding out what the topic is, we wanted to know how can we prevent it. So what we did is we did a lot of qualitative interviews asking people working in the institution what would work, and we came up with a catalog of 5 steps, 5 different domains of prevention. And it goes from information campaigns to measures that will change the organization, to training, to differences in the physical setup of the campus. So if there's certain areas that are dark at night and, some patients think that that's a good idea to attack you there, maybe we need to consider some physical aspects as well. They're really menial in a way, but they need to be considered as well. We implemented a lot of these. We're the only institution, the only academic medical hospital in Germany that has a button on the first side of the intranet where you can click if anything happens and you need consultation, you need to know, you need some support. We're the only one who actually has this, and we're doing quite well in that respect. The third part was legal. Because I don't think you can prevent sexual harassment in the long run if you don't have policies that you can hold on to and that help people in case of events. So what we did is we analyzed sexual harassment prevention policies in other areas of business. So anywhere from corporate to public institutions. There was none for medical institutions. We analyzed 120 of them and came up with best practice solutions. And with the best practice formulations on how to do a workplace policy, we did this open access book that anybody can download now. And anybody in Germany who wants to do a prevention policy for sexual harassment in the workplace can just take this and take the single steps and paste them together. So you don't need any knowledge about how you design a policy. You can just take the pieces and paste them together. So overall, as said before, you need the network. I'm not going to show you the network for this as well because I have 1 minute and I'm doing really well. So in conclusion, as I said, I covered quite a broad spectrum. I'm very happy to take questions afterwards. I'd like to thank my teams. I still have a team in Berlin because I still work a bit in Berlin. And I have my budding team in Radboud University. I wouldn't be able to do this without them. And of course, thank you all very much for your attention, and I'm happy to take questions afterwards.